delighted that you are here with us today. And I want to tell you to begin with a little bit about Chi. First of all, I'm the executive director of Congenital Hyperinsulinism International, but I'm also a hyperinsulinism mom, or an HI mom for short. And I want to tell you first off about our slogan, because it says it all. Our slogan is "Be My Sugar." And we mean it literally and we mean it metaphorically. And what Chi is all about is putting the life of HI. And we love hearing babies, so don't worry about that. But we want you to know that Chi is all about putting that sweetness in. And how do we do that? We do that by raising awareness of hyperinsulinism to prevent brain damage and death. And we conduct research and we support research for better treatments and cures. And we support families in so many ways. So that's really what our mission is. And while we're all about sweetness, this moment in time is really a bittersweet moment. And we know that so many people are struggling around the globe because of COVID-19, the virus. And our hearts go out to anybody who's lost family or friends, or anybody who has family or friends who are sick with the virus. We're so sorry. We're also sorry and know that the virus is making life very hard for anyone living with hyperinsulinism. We know that for some that might mean it's harder to get to the hospital, to appointments, to get medicine, to get supplies, to have people come in and take care of our children. We also know it just causes a ton of anxiety. And there's economic stress beyond what any of us could ever have imagined. So it's a bittersweet moment that I come to you today. And we're also kind of sad that we're not together physically. In the past, we've always been able to come together when we have a conference in person. And there's nothing sweeter or more special than seeing little children with hyperinsulinism find each other for the first time and give each other a hug. And they notice that other kids have backpacks and G-tubes and look similarly, maybe because of their diazoxide. And so we are sorry that we can't get together in person, but we are so excited that we're here virtually and that the whole world of hyperinsulinism is linked today and that the barriers to participating are lowered because here we are together virtually. So that is just amazing. We've never had so many people register for a conference. So thank you so much for coming. And it reminds us of our roots because when we first started Chi many, many years ago, we initially came together on the internet through a chat room. First, just 3 families. And now we're literally hundreds of people, thousands of people, and hundreds of families. I have a lot of people to thank today, and I have to start with our amazing sponsors who make this conference possible. It takes a lot to put a conference like this together, a lot of support. So first of all, huge shout out to our sweetest sponsor, Resolute. Thank you so much. And our platinum sponsors, Crinetics and Zealand Pharma, and our gold sponsor, Hanmi, and our silver sponsor, Beta Bionics, and our bronze sponsor, Amid Bio. And I also need to recognize the amazing Chan Zuckerberg Initiative that's included us in the wonderful Rare as One project. So the Rare as One project links 30 rare disease groups and gives us all sorts of technical assistance and funding in order to prioritize research and bring the patient experience into research and connect with clinicians and scientists so that we can prioritize research so that we can come to and accelerate the development of treatments and cures together. So that got kicked off in 2020, and we thank you so much. And now I need to thank the whole HI community, the board of directors of Chi, the patient families, and all of the academic institutions like CHOP and Cook Children's, and Exeter and Manchester and Gosh and Alder Hey and Odense and Queensland and Magdeburg for all being a part of the conference today. And also our sister organizations, the other great rare disease, congenital hyperinsulinism advocacy organizations working around the world together with us. I'd like to recognize the Children's Hyperinsulinism Charity and Congenitaler Hyperinsulinismus EV, and hyperinsulinismocongenito.org. We're all sister organizations working together for the benefit of the community. And now I'd like to introduce the Associate Director of Congenital Hyperinsulinism International, Jennifer Schmidt. Jennifer is going to tell you more about the conference. Jennifer, take it away.
Thank you, Julie. Hi, everyone. My name is Jennifer Schmidt. I'm the Associate Director of CHI and this conference. And I did want to tell you a little bit about this first virtual conference, and thank you for being a part of this grand experiment and the silver lining of this time that we get to come together this way. If you've made it this far, you have seen the virtual conference lobby and you found the auditorium. Please take some time to explore the other areas of the conference if you haven't already. Everything is accessible from the lobby. There's a help desk if you have any questions or need any help finding a session during the conference or if anything goes awry. The lounge is also found there from the lobby, allows you to chat with any of our conference attendees. And the exhibit booth hall is filled with wonderful booths from our sponsors and partners from around the world that Julie just mentioned. While you're in the booths and actually in the sessions, you are able to download any materials that have been shared here in the conference into your own blue briefcase. And then you can take these documents with you once the conference is over. You can download them to your own device. You will find this blue briefcase on the right-hand side of pop-up windows that come up throughout the conference. Also, I'm here to assist with anything that comes up during the conference. You can find me at the help desk throughout the days and in the CHI booth, so please leave a chat or send a message if you have any trouble or questions. And here are a few handy tips. Please keep your audio off unless you're speaking. Background noise can be troublesome for everyone. While you're in the main sessions, your audio is automatically turned off. Try to keep refreshments handy. We have a midday break, but otherwise we'll move quickly between presentations. And while you're in the main session, it's optimal to put your screen to speaker view. And if you're in a breakout session, gallery view will help you see all the other participants in the breakout session. And if you've registered for breakout rooms, you'll automatically be sent there to your assigned room when you join the afternoon session after our mid-conference break. You will need to re-enter your email address to enter the breakout room. And don't worry if you're not in a breakout room, not everybody is, and it's a great time to explore other areas of the conference. So we hope you have a really wonderful time and learn a lot over the next few days, and please reach out to us if anything comes up and you need any assistance at all. And now I think I'm going to send it over to our Research and Policy Director, Ty Pasquini.
Hi, Jen, thanks. So I am so happy to be here for the 21st HI conference. We are thrilled that the conference attendance really reflects CHI's commitment to be truly global. There are 513 people who registered from 42 countries. This represents 345 HI family members, 230 families, 118 physicians and scientists, 31 representatives from biotechs. We know the HI and other friends who have joined us across the rare disease community and friends of HI, individuals living with HI. We know the HI experience is global, which is why we have HI posters in 21 languages and continually connect with 3,999 Facebook followers from all over the world. That's not counting other spaces you may join us, including 1,500 members or followers on each of our social media sites, Twitter, Instagram, or in the Facebook Family Forum. It isn't a coincidence I'm sharing these statistics. As CHI's Research and Policy Director, I am so aware of how important statistics and data are to help us tell a story. One way CHI is committed to do this is through the Hyperinsulinism Global Registry, also known as HIGR. The registry consists of a series of 13 surveys made up of questions related to a patient's HI experience over their lifetime. When you join HIGR and share your HI experience on this secure platform, we can then anonymously combine your information with others' responses to help researchers have a more detailed and complete picture of the disease, which can help lead to better treatments, cures, and an overall experience for families. We will be talking about HIGR more tomorrow afternoon, and I hope that if you haven't already joined, you take the opportunity to learn more and to do so. And for those of you who already have, thank you so much for your contribution, and we'll tell you about all the ways you can continue to help tell the HI story through statistics and data. I'm now going to hop it over to Jana Pell to tell us more.
Hello, everyone. I am Jana Pell. I am Chi's Creative Communications Specialist, and I'm responsible for social media. So if you have reached out to us through those means, I'm most likely the one that you're communicating with. I'm also responsible for the graphic design for Congenital Hyperinsulinism International, and this year we've had a lot of really cool creations with the help of both you all, the Chi community, and my wonderful team here at Congenital Hyperinsulinism International. So one of those things is the Chibra, so keep your eyes peeled. There are little Chibras hidden all around the conference, and you can click on them and get virtual points for the chance to win a prize. So stay tuned for that. Another really cool and exciting accomplishment that we just completed was a new language for our Say Hi to HI infographics. If you have not yet seen our Say Hi to HI infographics, they are located in our Chi booth under the awareness section. And I'll also be in that booth answering any questions that you might have this weekend throughout the conference. And those graphics, I encourage you to look at all of them, download all of them, share them on social media. We have a bunch of Stop the Lows graphics as well. These are all hashtag campaigns that we've had in the past. And I really would love to have this opportunity to ask anybody who would love to help translate some of these materials into a language that we don't yet have, since we have so many people from so many different parts of the world participating in this conference today. So thank you all for your help in making my job easier.
Jana, Ty, Jennifer, thank you so much for sharing information about the conference and about Congenital Hyperinsulinism International. It is now my distinct pleasure and my honor to introduce a rock star. She needs no introductions because she's so well known. But here is Dr. Diva de Leon Crutchlow from the Children's Hospital of Philadelphia, who will give us a hyperinsulinism status report.
Hello, everybody. Welcome to the conference. It's really fantastic to have the opportunity to spend these 2 days with you. As Julie mentioned earlier, it's sad that we cannot see each other in person, but I'm very grateful for this opportunity that Chi is giving us to come together as a community. For the next 15 minutes or so, what I would like to do is to take you through a journey looking at the past of hyperinsulinism, where we are as a community when it comes to diagnosis, treatment, and outcomes, and leave you at the end with some thoughts about priorities that as a community we should be working on. And indeed, in many of these areas, there have been progress in the last few years in moving into a direction that will bring better outcome for our patients. So the first description of hyperinsulinism dates back to 1954. At that time, Macquarie described what he named idiopathic spontaneously occurring hypoglycemia in infants. And in 1955, it was recognized that hypoglycemia in this familial form of hypoglycemia can be triggered by amino acids. But it was the discovery in 1960 of the immunoassay to measure insulin in plasma that allowed to make a connection between insulin, a hormone that lowers glucose levels, and this idiopathic hypoglycemia of infancy. This discovery made it possible in 1975 to change the term idiopathic hypoglycemia for congenital hyperinsulinism, as we have known this condition since then. And more importantly, defining the criteria for the diagnosis of hyperinsulinism, as outlined here: hyperinsulinemia, hypoketonemia or low ketone levels, free fatty acidemia or low free fatty acids level, and a hyperglycemia response to glucagon. In 1981, there was a recognition that what has been believed to have been a disorder of embryogenesis of the development of the pancreas was not really a embryogenesis defect, but a molecular problem. And in 1989, the recognition that there were two histological forms of hyperinsulinism were first described with the description of a form of hyperinsulinism that affected only a very small part of the pancreas, of focal hyperinsulinism. The discovery in 1995 of the ability to clone the sulfonylurea receptor component of the KTP channel really started the genetic era of hyperinsulinism with the discovery of mutations in this gene as one of the most common forms of hyperinsulinism. Probably one of the largest milestones in the history of diagnosis of hyperinsulinism was the description of the use of 18-fluorodopa PET imaging to localize focal lesions prior to surgery, which happened in 2004. And since 1995, with the first description of mutations in the sulfonylurea receptor, there have been an expansion in the understanding of the different genes that are known to cause hyperinsulinism, and also an expansion of the ability to do genetic testing with the ability to test multiple genes in one genetic panel. So we know now that hyperinsulinism is the most common cause of persistent hypoglycemia in children. If we look at the population of infants that present with persistent hypoglycemia, as depicted in this graph, about 3/4 of the cases are caused by hyperinsulinism. But this is a rare condition. The estimated incidence is of 1 in 20,000 to 1 in 50,000 live births, which translate into about 80 new cases in the United States every year. But we believe that this is a marked underrepresentation of cases, and that probably refers to only the most severe cases that require surgery. So we really need to define the incidence of hyperinsulinism and the prevalence of the condition, and the HI registry is going to be incredibly helpful in determining this prevalence. As I mentioned before, the clinical diagnosis of hyperinsulinism is made based on the finding of high requirements of glucose to maintain normal glucose levels, the finding of high insulin levels at the time of hypoglycemia. The most useful biochemical testing is the evidence of low ketones. It's the most sensitive and specific test for hyperinsulinism, low free fatty acids, and that glycemic response to glucagon. But there continue to be some challenges and opportunity when it comes to the diagnosis of hyperinsulinism, particularly because we now understand that there are many atypical presentations. And these children that have atypical presentations, frequently this results in late diagnosis and inappropriate treatment because the diagnosis is not done early on in life. Also, in many areas of the world, the lack of access to biochemical testing prevents the prompt diagnosis of hyperinsulinism. In terms of the molecular diagnosis, we know of more than 12 causative genes of hyperinsulinism, as are highlighted in this figure. The use of next generation sequencing panels that include 9 to 11 genes allow for testing for mutations in multiple genes at the same time. In many places, the approach to do rapid testing for mutations in the KTP channel allows for the identification of those children that would benefit from having imaging for focal hyperinsulinism. There's testing available for syndromic cases of hyperinsulinism as well. But the access to molecular testing continues to be a challenge for many of our cases because of cost, because of availability, and sometimes because of knowledge, because this limitation is not only present in countries where there's no molecular testing available, but even in developed countries where testing is available, many physicians do not know how to do it and do not understand the importance of establishing a molecular diagnosis. The interpretation of the results is also a challenge because very frequently when we find a variant in a gene, it's not known if that variant is disease causing. And importantly, negative results of genetic testing, even when we use these expanded next generation sequencing panels, is very frequent. About 64% of the disoxide responsive cases are negative when we test for all these genes, and about 10% of the disoxide unresponsives. And this is probably a result of a combination of factors, including the fact that we don't know all the genetic causes of hyperinsulinism, and also that in some cases, the mutation is not present in all the cells of the body. So when we test the peripheral blood, the genetic testing may be negative, and the mutation may be present only in the pancreas. We're going to talk about now about the evolution of treatment of hyperinsulinism. It was in 1964 when disoxide was first described as a treatment for hyperinsulinism. At the time, the authors that published this report described that the use of disoxide allowed for the management without surgery of about 50 to 60% of the cases. So there were still some cases that could not be treated medically. In 1977, the use of somatostatin to treat hyperinsulinism was first described, but somatostatin have a very short half-life, so the effect didn't last long. So in 1986, the use of the somatostatin analog octreotide was first described. And at the time, these authors estimated that about 29% of the cases could be managed without surgery with the use of octreotide. A revolution on treatment really came around 2004 when the use of 18-fluorodopa PET allowed for the identification of focal lesions prior to surgery. And then since then, there had been a lot of reports about alternative treatment for diffuse hyperinsulinism other than near total pancreatectomy. In 2008, Klaus Monique described the use of a continuous infusion of glucagon to treat hyperinsulinism without using surgery. In 2011 and 12, the first reports of the use of the long-acting somatostatin analogs, lanreotide and long-acting octreotide were described. We described the potential use of a new investigational treatment, extending 9 to 39 to treat hyperinsulinism in 2012. In 2014, Khalid Hussein described the use of sirolimus to treat infants with severe hyperinsulinism. And since then, there had really been an explosion of investigations for new potential treatments for hyperinsulinism. And you'll hear some more about this in the following talks. So what are the goals of therapy for hyperinsulinism? The immediate goal is to promptly restore plasma glucose to the normal range of greater than 70 milligrams per deciliter or greater than 3.9 millimolar per liter for those that use those units. The midterm goals are to identify the optimal treatment regimens according to the type of hyperinsulinism and to maintain normal plasma glucose concentrations while encouraging normal feeding and diet. And the long-term goals are to prevent brain damage from hypoglycemia and also to promote normal life and development. And we should not forget this last item. So I'm going to talk a little bit about what I envision should be the optimal treatment for hyperinsulinism. So I have to introduce the concept of precision medicine. And this is the use of an individualized treatment plan according to genotype, and therefore genetic testing results are incredibly important to be obtained, but also according to the phenotype, according to the clinical manifestations, which sometimes we have to do a specialized treatment evaluations to understand. So this individualized treatment plan requires a comprehensive investigation to understand all aspects of the condition. Different treatment options are also required because one treatment modality may not fit all. And this is where the development of new therapies comes into play. This is why it's so important that we facilitate the development of different new treatments, because it's very likely that the same treatment would not be an option as we have sent for diazoxide for all patients. So is this possible for hyperinsulinism? I think we are already doing precision medicine for focal hyperinsulinism and sort of for no focal hyperinsulinism. It's a little bit more complicated for the diffuse cases, but comprehensive investigation and new treatment options are gonna make this possible for diffuse hyperinsulinism as well. Now, what are the challenges and opportunities when it comes to treatment? I already mentioned that we have only one FDA-approved drug to treat hyperinsulinism, and this is diazoxide. But we know that about 60% of the cases are unresponsive to diazoxide. Importantly, diazoxide is not available in many areas of the world. A few years ago, Congenital Hyperinsulinism International conducted a global access survey asking physicians if they had diazoxide available for their patients. And 60% of the respondents answered that they did not have diazoxide available for their patients. So access is also a problem. We also had the challenge of ongoing monitoring for side effects of therapy, and more importantly, for glycemic control. So should we use glucose meters or should we use continuous glucose monitoring systems? And I told you a little bit about this in the next slide. The need for monitoring in the inpatient to assure that the treatments that we have established are appropriately preventing hypoglycemia, and the need to monitoring not only glycemic control, but also growth and development. So a couple of years ago, we did a study in 14 children with persistent hypoglycemia due to hyperinsulinism to evaluate the utility of continuous glucose monitoring systems. At the time, the Dexcom G6 was not available, so we conducted this study using Dexcom G5. By definition, the children that we included were children that were not completely controlled with the current treatment options and will continue to have hypoglycemia. What we found there was a high frequency of false positive lows. This use of continuous glucose monitoring may be helpful for children with glycemic variability, but may not be that helpful for children who are well controlled. Another limitation is the cost. This is approved for the use in diabetes, no hyperinsulinism, so very frequently it's not covered by insurance. And in this graph, you can see that very frequently when we had measurements that were reported to be low, those were falsely low readings and needed to be confirmed by a glucose meter. So I post that at this time, the continuous glucose monitoring systems may be helpful in some, but not all of our patients, and that we should advocate for these systems to be accessible, but more importantly, more precise for our patients. So when it comes to treatment, the challenges and opportunities that are ahead of us as new therapies are developed are the lack of longitudinal natural history data, the limited number of patients for clinical trials, the heterogeneity of the patient population, the medical vulnerability of the patient population, and there is no doubt that the path to approval is complex. So finally, just a review of the outcomes of hyperinsulinism. In 1954, McQuarrie, when he described idiopathic hypoglycemia of infancy, described irreparable brain damage for from the severe hypoglycemia. And throughout the years, we have seen multiple reports from all over the world that describe the same high rates of neurodevelopmental deficits as a result of hypoglycemia. And this is despite the fact.
I'm so sorry, I'll let you finish the last thought, but we need to keep our program moving. So if you just want to.
Yes. Yeah, so I'll go to the last slide and review with you what I see as the research and clinical priorities. We need early diagnosis. We need precise diagnosis. We need a personalized approach to treatment. And for this, the registry is going to be incredibly helpful. The establishment of centers of excellence. We need new treatment guidelines, improved tools for monitoring glycemic control, and we need new effective therapies. And of course, we're going to need better access to medications for children all over the world. Thank you very much.
Thank you so much. And I'm so sorry to cut you off. I know that we could talk to Dr. DeLeon all day, and we will have an opportunity to hear from her later today and ask the experts. But it is now my pleasure to introduce Erin O'Boyle from Resolute.
Thank you, and thank you, Chi, for pulling off this virtual event. So this is great. It's a great honor and pleasure to be speaking on behalf of Resolute today. My name's Erin O'Boyle, and I head up the clinical operations for Resolute, which is located in Redwood City, California. Our primary focus at Resolute is for really finding better treatment options for rare, life-threatening diseases. And currently our lead program, and why we're here speaking with all of you today, is for RZ358, which has the potential to be a novel and impactful treatment for Chi. Essentially, RZ358 works in a unique way compared to current standard of care. Just to let you look at the screen a little bit in the picture, RZ358 works at the insulin receptor to essentially dampen excessive insulin effects around the body, such as hypoglycemia, all the while still allowing normal levels of insulin functioning that the body needs. This unique type of mechanism of action would be expected to work with all genetic subtypes of HI. Previously in clinical studies, there's been 59 participants that have received RZ358, including 5 pediatric patients with CHI. All doses to date have been safe and well tolerated, and there's been no identified safety risks thus far. In the 14 patients that did receive a single dose of RZ358, the data showed improved hypoglycemia, as well as maintained normal glucose levels without hyperglycemia for a period of 2 to 4 weeks. This data shows the potential that RZ358 could be given twice monthly or even monthly for a short 30-minute IV infusion. Currently, the study that we have ongoing right now, officially called RISE, is, just to summarize at a very high level for all of you, it's an open label study, meaning that every participant will knowingly receive RZ358 in one of 4 sequential cohorts. That each will test a certain dosing regimen for the safety and glucose control. Once the patients are deemed eligible for the RISE study, they'll continue on for an 8-week period of treatments, and then they'll be followed up for an additional 3 months. Some of the tools that we're going to be utilizing in the RISE study, all eligible patients will be provided an unblinded Dexcom G6 for their continuous glucose monitoring, as well as a glucometer to record their glucometer values as part of their standard of care, and is also a self-check for any low values that are seen on the CGM. Patients are also going to be given an e-diary to record their daily glucose events, as well as any changes in their diet and exercise. We're also going to be taking blood samples throughout the study in order to determine an optimal dose for phase 3, but also to study and evaluate the safety and drug effects. However, I do want to stress that we'll be collecting a minimal amount as possible so that no excess blood is taken from any patient, and only that is taken for what is required for the study analyses. So where are we at right now with the RISE study? Currently, we have approval in 8 countries. Russia was actually just recently approved, so they've joined the list of approved countries. You'll see that US is in orange. We're expecting to have them up and approved by the end of July, and with the remaining countries to come on board and be ready to start screening by early November. Actually, just prior to COVID, that hit and we had to shut down, we actually enrolled our first patient in the study in the end of February, who has since completed all treatment and is doing quite well. Lastly, Resolute received in June rare pediatric disease designation from the FDA. And just in closing, and with everyone's in the community help and support and participation, we're really excited to be partnering and conducting this study. And everyone that you see listed here from the Resolute Clinical Operations team, as well as our scientific medical experts from Dexcom, are all here and will be available throughout the meeting. So if you have time, please feel free to visit our virtual booth, and we're happy to answer any additional questions of those of you that you may have. So thank you so much, and thank you for Chi for putting on this virtual event.
Thank you so much, Erin. Really interesting and great to hear what you're doing over at Resolute with the RISE study. And now it's my distinct pleasure to introduce you to Dr. Clara Owen. Dr. Owen is with Zealand Pharma. So Dr. Owen, join us.
Sorry for the slight delay. I just got a little spooked by so many things happening at the same time. Thank you so much for having me as a representative of Zealand Pharma speaking at this first ever Chi virtual event. I have to say I have been with Zealand for 3 years and involved with Chi for those 3 years. And every time I participate with anything organized by Julie, it's always first ever. So hats off for coming up with so many interesting and new ways how we can all interact. So since I have been speaking to you at events before, I am going to use the 5 minutes for a quick update on our clinical trials that are ongoing with dasiglucagon. A quick forward-looking statement. So for those of you who have not heard about dasiglucagon before, dasiglucagon is a stable glucagon analog, meaning it's a drug that has been inspired by the body's natural defense against hypoglycemia, the #1 defense being glucagon. It's like the counterbalance to insulin. And the drug has then been made into a compound that can be formulated in essentially a water-based solution with a fast onset of action and suitable for multiple indications where hypoglycemia is an issue. The first of one is already filed to the FDA as a new drug application, and that is a rescue pen for severe hypoglycemia. The second in line will be hopefully a drug that sorry, I just got a message from Julie that you can't see or hear me. Let me see if I can fix that.
We hear you. We hear you perfectly. We just don't see you.
Okay, I'm sorry. Okay, let's see if this would fix it. I hope it does.
We see you.
Oh, fantastic. Sorry about that. Let me just go back to the slide then. Excellent. So for the Chi, I will give you a quick update on where we are in the clinical program for your children. I also want to mention the dasiglucagon is also being developed for the dual hormone artificial pancreas. And for those of you who have been to the family conference last year, you have heard Ed Damiano talking about the fantastic pump that can dose both insulin and glucagon based on a very sophisticated algorithm that basically ensures that diabetes is well controlled. We also developing dasiglucagon as a mini dose pen for correction of hypoglycemia. This is not yet very severe, and maybe one day this would also be something of interest for children with Chi. There we go. So when we're looking at dasiglucagon in Chi, we are looking at two distinct uses. One would be before you receive the final diagnosis of what type of Chi you have, how severe it is, and how can it be optimally treated, going back to what Diva De Leon was talking about in terms of precision medicine. So in that early stages where you know something is wrong, you know your child suffers from hypoglycemia, we are envisaging that dasiglucagon as an infusion would buy you an extra peace of mind that your child will not crash and drop extremely low whilst you're spending time figuring out with what works and finding that optimal treatment for your child. Now, after you receive the final diagnosis, some of you will want to consider whether medical treatment would be something that you would like to do, essentially achieving a normal or near normal glycemia without having to use a pancreatectomy in the diffuse cases, and therefore also reduce or completely eliminate the risk of type 1 diabetes that often happens after a large extent of pancreas has been removed. So I'm not having a very good day. I'm so sorry. Let's see whether I can get the next slide on. Fantastic. So what I would like to say is that overall, dasiglucagon, we believe, could provide a non-surgical treatment option. It is a drug that is already ready to use, stable at room and body temperature, formulated in what is a water-based solution. We have the fantastic news for this update that all our 3 phase 3 trials are ongoing. And if I can just show you what these 3 trials are.
I'm so sorry, Clara. We're
Yeah?
going to share the information with attendees in afterwards in the presentation because we need to keep our program going.
Okay.
So much for the information, and we'll
No
be
worries.
information with all attendees. Thank you so much.
Thank you.
It is now my pleasure to introduce Julie Gettings, who is joining us from CHOP, and who will be starting off our session on coping with the stress of parenting a child with complex medical issues. So I will pass it over to you, Julie.
Wonderful, thank you. It is a pleasure to be here. I'm trying to share my screen, and it says that it's disabled participant screen sharing. And so, Ty, can you see my screen?
Not yet, but we will make sure that you can do that.
Okay, let me try again.
No.
Here we go.
There.
All right, wonderful. Hi, everyone. I understand if it's a little confusing. I think my screen says Julie Raskin. I'm an imposter Julie Raskin. I would love to be like Julie Raskin. However, I am Julie Gettings. I'm a psychologist from the endocrinology and diabetes program at CHOP. And honestly, I am thrilled to share this talk with you, and especially now more than ever. You know, I think if anyone has a reason to be stressed, this is it. We're in the midst of a global pandemic. We have, you know, different stressors going on, homeschooling, working from home, health issues, etc. So I'm happy to be here. Here's our plan for today. I want to talk a little bit about just stress in general, parenting stress, risk factors and protective factors for coping, some ideas for coping to really hopefully give you some take-home points after today's talk, things to think about differently or maybe do differently. And then finally end with some possible resources to consider. So the first thing I want to mention is when we think about stress, often it's this diffuse general feeling of stress. like everything feels stressful. I'm so overwhelmed. This is so hard. And so as we think about undoing this process or coping with stress, the first thing I would encourage people to do is get specific. What specifically is stressful? You know, and this could be positive things we call eustress, you know, planning positive, you know, family outings, a wedding, you know, things that are meant to be positive. It could be distress, negative stress, you know, coping with medical issues, Dexcom alerts going off all night, you know, making medical decisions, things like that. The other thing I'd encourage you to think about is different tiers of stressors. You know, especially now more than ever, some stressors are occurring globally, you know, at an international level, national level, in our state, community, in our house, in our minds. And so generally the closer the stress is to us internally, the more control over it we have, and the easier it is to find ways to cope. When we think about stress specific to parenting a child with chronic health issues, it really, what the research shows is that it really requires a high level of emotional engagement, personal commitment to your child. You probably don't need me to tell you this, you know, that it takes an investment to really get through some of the day-to-day. You know, having a child with chronic health issues may be associated with increased stress. Again, may not be surprising, but just these overwhelming feelings of being powerless, helpless, you know, and especially for our population here, maybe there's some guilt, maybe there's some blame. I should have done something differently. And so as we talk about coping, you know, I challenge you to identify scenarios in your mind or you know, personal situations or personal characteristics that may relate to you, and we can think through how to help with that. Now, again, just briefly about the research, what the research shows us is that these factors put people at higher risk for coping difficulties. So if the disease is more severe and impairing, if your child has more difficulties with being independent and doing daily tasks. If you're personally someone who perceives stress as being more burdensome, someone who has trouble with, you know, daily hassles. So this is things like, you know, I tripped on the sidewalk, I burnt the toast this morning. You know, someone who gets hung up on those daily hassles is really more at risk for having these coping difficulties. Now, on the flip side, there's protective factors. And so this basically has to do with how people cope, you know, how they perceive events and situations. And so our brain is wired to look for threats, right? So there's a tiger here, and so our brain is connected to the rest of our body, obviously, so that when we see something threatening, our body responds in a way that we get ready to fight it, we get ready to run away, the fight or flight response. The challenge sometimes is that you know, our mind gets trained in a negative way, that we appraise events or judge events as threatening, when maybe in actuality they're not actually threatening, or maybe they're just a little bit threatening. You know, maybe it's, you know, a cat that, you know, maybe we want to be concerned about, we don't want to get scratched, but we perceive it as a tiger. So when it comes to especially interpreting health information, we want to try to appraise things appropriately. We want to try to, you know, get objective judgments of what's happening, and appraise them in a reasonable way. What we know in terms of, again, healthy coping, when things are in our control, people who can use problem-focused strategies tend to do best. And this, again, might seem pretty obvious, but if there's a clear problem and it's something in our control, and we can use strategies to help with the problem, that's most helpful. So for example, you know, if your child is struggling with math, and you know you can get a tutor, or you know you can enlist help from the neighbor, it makes sense. In other situations, things are out of our control. Maybe coping with a new diagnosis. Unfortunately, there's not much we can do to fix that per se, to change the actual event. However, we can do things to cope with the emotions, right? We can talk to friends for support. We might meditate. We might pray. Things like that to help us cope with the emotions, rather trying to change something that's out of our control. Other things to keep in mind: protective factors. Personally, generally, if you were psychologically healthy prior to a diagnosis in your family, if you had an internal locus of control, meaning that you feel like you have the agency, you have the ability to change things and make things better, that's more helpful. And generally in your environment, if your family is functioning rather well, if you can co-parent well with a partner, if there's not a lot of family conflict, things like that, you have good social support, you're coping well with the diagnosis, and you're connected with resources. And let me really emphasize that, in terms of parental adjustment, whether it's HI, whether it's something else, kids take our lead. As parents, they look to us as models for how to cope. And besides that, how we're coping affects how we parent. If we're upset a lot, if we're down, if we're blaming ourselves, that's going to come out in terms of how we discipline. Are we disciplining or letting things go because we feel guilty, or things like that? So how parents adjust matters. So now let's get into some ideas and some strategies to consider. Self-care, more than ever, has become increasingly necessary, and it's really hard. One of the most common things I hear from parents is, I just don't have time. I don't have time to exercise. I don't have time to go for see a friend, or go out and do something for myself. And it's just so necessary now more than ever in the current climate, and as we cope, with the daily hassles of life. So this includes caring for your mind and your body, right? And so physically, emotionally, socially, spiritually, truthfully, it may require us getting creative these days. It may not be going out to lunch with friends anymore due to COVID, or doing that in a safe way. I challenge you to think creatively about self-care. This might be taking a few deep breaths. And so, before you go and talk with your child about something, or talk to a co-parent about something. It may be, trying meditation, or trying yoga, something different, something to, switch things up a little bit to take care of yourself. I was looking to be creative during this quarantine time. And so commonly I heard this, but I decided to start a gratitude journal, trying to find things I'm grateful for each day. Certainly there's plenty of things to, feel stressed about. Although the more we can appreciate, the more, our mood is better. And so doing that is a way to care for yourself. Finally, thinking about ways to reward yourself. I can't emphasize enough how much all of us are going through as humans and as parents. So, maybe it is you made it through a week of, working from home and trying to teach your child at the same time, finding some way to give yourself a break, or, if you're able to, I don't know, get takeout that night, or give yourself, a special treat, whatever the case may be. We have to really be mindful of this. The next thing I want to talk about in terms of coping is emotion regulation. And this is, essentially a psychology term that has to do with keeping yourself calm and keeping yourself in a place where you're able to be rational and be an effective parent. And so when we parent young people with a chronic illness, again, there's a lot of emotions that come up. We might be angry, we might be sad, we might again, be guilty and be blaming ourselves. And when our emotions are more intense, then our rational thought is less clear, right? So when emotions are high, our rational thoughts are low. And so it's up to us to really be able to recognize these times where maybe our emotions are high. We need to get ourselves in check a little bit. I often talk to parents in clinic that I really truly believe, don't quote me on this in terms of any statistical validation, but I really believe about 90% of parenting is being able to keep yourself calm. You probably know what to do in certain situations. It's just a matter of calming yourself down and being able to be present and being helpful. So in these situations where you notice yourself maybe getting negative, feeling negative, it's really important that you're able to be mindful. Okay, this is one of those times. I'm getting really angry. I'm getting really upset. Why didn't my daughter, change the CGM? Why didn't they let me know that this needed to be done? Whatever the case may be, being able to stay calm in the moment. Maybe you're breathing. Maybe you distract yourself for a moment. And then in the longer term, practicing some of those self-care options over time to help keep yourself healthy and really try to keep your baseline level of stress or reactivity to a lower level. The other thing as we think about coping that I challenge you to do is think more about your thinking. We all have negative thoughts that happen. Whether it's about ourselves as parents, whether it's about ourselves in general, the future, are you realizing that these thoughts are happening? It's common for us, especially these days, that you or I might go through the whole day and not even stop to think about what we're thinking about. Like, have I been in a grumpy mood all day? Well, what have I been thinking about? I've been worrying about school in the fall. I've been worrying about my job. I'm paying bills. And of course I'm going to be grumpy, And so it's important that we have some awareness of what we're thinking and we're able to hopefully assess these thoughts a little bit. Or is what we're telling ourselves true? Is what we're telling ourselves even helpful? Thinking about the future for your child. My child won't be able to do this, or what if they don't do well socially? What if they don't get married? Or, we don't know that these thoughts are true. We don't know that these things will for sure happen. And certainly we can say in most cases that these thoughts aren't helpful. So again, as we think about coping, really raising your awareness of how you're thinking and doing your best to reframe your thoughts. This doesn't mean needing to be super positive all the time. It doesn't mean being your own cheerleader. It means sometimes being able to just be neutral, being able to say like, okay, right now I don't need to worry about this. I'm going to try to, do what I need to do today and leave that for a later time. This was, I thought, a nice graphic, in terms of our current situation with COVID, with managing young people with health issues, with all the decisions we need to make, really trying to focus on things we can control and things that we can't control, and knowing the difference. And so things we can control always is our attitude, how we follow health recommendations, how we limit our time looking at external sources that may or may not be helpful. Social media these days can be a blessing and a curse, right? It's nice to stay connected with people. However, is the way that we're using social media really helpful? So I'd encourage you to think more about that. Another thing I wanted to bring up today is really a framework about decision making. This is from Emily Oster, who's a behavioral economist from Brown. And essentially her job is to, help people think through how they make decisions about things and what can be helpful. She's particularly an expert with parenting. And so I wanted to bring this up. Her framework for decision making, as we all feel stressed these days and maybe overwhelmed with decisions, it's really helpful at times to have some objective way to look at our stressors, or look at what we can do and what we can't do. So the first thing she suggests is that we really frame the question that is the point of contention, or seeing what, you know, is there something that can be solved here. So for example, you know, I think as parents, a lot of us are worried about, you know, school, or maybe we're worried about a health decision. And so what is the actual question? Is the question, you know, I'm thinking about doing a CGM or not a CGM? Is the question, I'm thinking about going to the grocery store with my child or not going? And so trying to be as specific as possible about our question. Next, as we make decisions, see if there's a way to mitigate risk. Can we, you know, wear masks, wash hands? You know, these are all ways to mitigate risks in our current climate. Evaluating our risks versus the benefits. Well, you know, am I able to go to the store at another time without my child? Do I need to take them? Do we need something today for their health? Do we need to get prescriptions today? And so evaluating the risks and benefits, and then making a decision. If it's possible, you know, I would add, see if you can do a test period, try something out maybe for a couple weeks, and see how it's working, see if you need to reevaluate your decision. Another thing I challenge you to think about is really putting the illness in its place. So as we think about HI, there are certainly opportunities to worry or be mentally consumed if you choose to be throughout your day. Now, certainly having a young person with a chronic illness can lead to these challenging situations, and we can certainly learn from them. At times, it really requires us to almost have a space for these things in our brain, to know things happen, to know things are hard, while also being able to still enjoy life and engage in meaningful activities for ourselves and with our child and with our family. So I challenge you to think about this in terms of almost giving yourself permission to do other things and enjoy other things, while also, you know, in the back of your mind, understanding the responsibilities you have to your child's illness, understanding situations that may have happened. So finally, some resources to consider, and if we have a few extra minutes, I'm happy to take some questions. I think my screen is blinking a little bit here. So resources to consider. You know, this isn't easy. I'll really emphasize that point that, you know, it's so wonderful that you're here today with this wonderful community of people, many people who are going through similar concerns and questions that you may have. So it really can help to get connected to other people, maybe finding support groups through CHI or through your medical team. For some people, it's really challenging to cope, you know, and this is just inevitable. And so it may help to look into options for therapy, either individually for yourself, for the family, for you and a co-parent. There's resources at CHOP that are available, some local resources, and it doesn't always have to be a forever thing. You know, sometimes people see a therapist for ideas, and, you know, and that's it. And you go one time. Other people can go continuously and everywhere in between. So think about your resources, think about further support you may be able to get. And another great option is advocacy. This can be very helpful for families to be involved, to make meaningful differences in the CHI community, in an international level, national, local level, whatever the case may be. These can all be helpful. So some final thoughts to keep in mind. You know, this is hard. This is certainly hard, although coping is within your control and it takes practice. And so, again, some of these things I discussed today are meant to give you some ideas, and hopefully you can develop some of your own coping strategies that work for you. They might not work for everyone, but finding something that works for you. Now more than ever, please take care of yourself, whether this is a day to yourself, an hour to yourself, a moment to yourself. Please, you are so important to keeping yourself healthy, your family healthy, your child healthy. And so that's so key. Things that may be helpful are managing your emotions, your thoughts, your behaviors, as we discussed today. And of course, outside resources may be useful in coordination, also in coordination and consultation with your medical team. So this is, as I said, such a great forum today to connect with other people and hopefully get some support if you're looking for it, maybe connect with people. So on a regular basis, you can keep up conversations or relationships. And so hopefully you can utilize that time today to do so. So I want to thank everyone for their attention. I'm happy. I see we have a couple extra minutes. If there's anything.
Hi, Julie. Well, thank you so much for the great presentation. And it looks like we do have a few minutes for questions. I received one from Dina, so I'm going to try to let you ask directly. So we'll see how this goes. Go ahead, Dina. You should now be able to ask your question if you unmute your microphone, which I'm trying to unmute for you. Okay, you should be good now, Dina.
Can you hear me?
We can.
My light's a little wonky.
Oh, that's great.
Apologize for that. So really my question was, as I watched your presentation, Julie, thank you, I started to think about my daughter who's transitioning with HI into adulthood. And I am actually seeing some of the anxiousness and stress show in her. And so really everything that you talked about that we can do as a parent really applies to her right now. And some of the things we've been trying to help her, like identifying, like really acknowledging her anxiety and stress and ways to manage it and cope with it. But do you have any other advice as we have these children who are transitioning into adulthood?
Sure. So thank you for your question, Dina. I think, you know, there's a couple things to keep in mind. One is really validating her concerns. This is a hard time. You know, I said that a few times, but you know, in terms of navigating adulthood, that's stressful enough. And then doing that in the midst of the current pandemic, the current climate. So being able to be emotionally supportive that, yes, this is challenging. Absolutely, we hear you. And also giving the message that we are going to get through this and we're going to make sure you're ready. Commonly, what can be helpful for young people as they transition, you know, into adulthood is doing little experiments, right? And so being able to give your child evidence that they can do things on their own. And so this may start with coming up with goals that are really achievable, you know, whether it's, you know, you remembering to do this task rather than me, or, you know, getting themselves on a daily routine on their own, working up to getting their own prescriptions or communicating with the medical team, and really taking a gradual approach so that there are opportunities for you to help your child build confidence, you know, in this process. So it doesn't seem like such an overwhelming thing that gradually they can see themselves and you can help support them with their progress. Finally, I would remind you that therapy can be a helpful option, or at least consultation with a therapist if you find that the anxiety is interfering with daily functioning or interfering with the ability to complete some of those tasks. you know, it's common for young people with chronic illnesses to benefit from meeting with a psychologist. That's why we have a whole team of them at CHOP, that this is just becoming the norm. And so really being able to support your child's mental health and normalizing that this is a just included part of their medical care.
We have one more, probably time for one more quick question, and one that I think a lot of people are wondering. With schools about to open, a lot of people are very stressed, especially here in the US, but I'm sure across the world. Any advice about how to deal with that additional stress of the school?
That's a tough one, man. I wish someone could help me with that as well. I think, you know, the same would go in terms of normalizing. You know, I'm thinking back to the model I talked about with Emily Oster, thinking about mitigating risk as much as possible. Often kids will have the same fears we do. They worry about getting COVID-19, and it's perfectly fine. In fact, it's healthy for us to share that we're worried too. The addition that is really necessary in terms of helping with coping is reminding them that we're doing everything we can to keep things as healthy as possible and as safe as possible. And reminding them, yes, it is scary. We've never done this before. And that's why we always wash our hands. And that's why you're going to wear your mask at school. And that's why, you know, we always carry hand sanitizer or whatever the case may be. So really, as parents, being able to validate the emotion and then also, you know, essentially end the sentence with what you're doing and how you do have control over this and how you're doing your best to make the situation better.
Still on mute. Thank you so much, Julie, for the wonderful session.
Thank you for having me.
Julie Raskin.
Hi. Hi, can you hear me? Great. So Julie Gettings, thank you so much for that amazing, amazing talk. Stress is really the middle name for all parents with hyperinsulinism. It's just a universal issue, and for a lot of the kids too. And we really, really, really appreciate your talk. I want to apologize desperately for the issue that we had with stopping some of the amazing talks. So just apologies, and during Ask the Experts, you're going to be able to ask your questions of Dr. DeLeon and of Dr. Owen. And I also forgot to mention the Royal London Children's Hospital and the Endocrine Research Center in Moscow as partners. And now we're going to start a wonderful session, a video called HI Stories, where we're going to have a couple of the families present their experiences. So, Jeff, please start the video. Thanks so much.
Hold on, we're having a little trouble with sound.
Hi everyone, thanks for bearing with us. We're just working on the sound issues and hope to share the videos with you shortly.
All right, let's try it again.
Requested it to be, it was 12. Second glucose check was not able to read on the hospital glucometer. She was immediately taken away to be put on oxygen and dextrose, which required her first IV. Diagnosis came 6 days later, and 12 days later she was transferred to CHOP. While at CHOP, we learned she had an ABCCA mutation and underwent surgery when she was 1 month old. She required a 98% pancreatectomy, and it was determined that she needed a G-tube as well. Skin biopsy was taken at the time, and Beckwith-Wiedemann syndrome was also confirmed later. We had many challenges along the way. Managing Alina's blood glucose to avoid brain damage has been extremely tiring and demanding. We had to learn how to take care of a baby that had different needs than a typical baby. We found ourselves doing blood sugar checks and G-tube feeds every 2 to 3 hours around the clock. And even then, she struggled to maintain her blood glucose up above 70. She was connected to continuous D20 the first 2.5 years of her life. Her regimen, however, changed a couple of times to best fit her needs. She at one point required 2 different pumps running overnight to keep her safe. The fear of brain damage was and still feels very real. Hard time dealing with loud noises and sudden movements. Alina was unable to bear weight on her feet until she was 19 months old. As a result, she started walking until she was 21 months old. Trying to balance life the first 2 years was challenging. We had countless doctor appointments and we were trying to function on 4 to 5 hours of sleep, all while dealing with post-traumatic stress. I found myself grieving for the baby I thought I was going to have, grieving the fact that I was not able to be the mother I used to be to my 2 older children. Alina's disease consumed all of my life, my time, and my attention. Hyperinsulinism has taken a toll on our family and I. Alina's father works 2 jobs to support our family, and I had to quit my job to care for her. My mom has also needed many days off from her job to help with appointments and hospitalizations. Congenital Hyperinsulinism International has created a community where I feel we belong. Being able to connect to other parents who can relate to our struggles is a blessing.
Hi everybody, we are the Greetabacks from Wisconsin, and so I'm Carissa.
I'm Kyle.
And this is Elsie, and Elsie is our second daughter, and Elsie was born with hyperinsulinism. We have 2 girls, our oldest Evie, 4 years old, and then we just had Elsie last August, so she is nearing in on nearly a year old, which is crazy.
Yeah, it goes fast.
And what a ride and roller coaster it's been. So fast forward, we spent over a month in the NICU. Every blood sugar draw was like taking my breath away. It was like you were living in these 3-hour increments, and no one really could tell us like the rhyme or reason of why this was happening. Otherwise, she was a typical healthy baby. So at 14 days old, she had a pretty significant low. We did the critical labs, and it was determined that her body was producing too much insulin, and that was counteracting the sugars. And they told us a really scary term and said, don't Google this, and that was hyperinsulinism. So we work with the team at Children's Wisconsin, and at 14 days old, she's diagnosed. She got started on diazoxide. It works for her, which is great. We spent another 2 weeks in the NICU, came home, and then obviously, like all of you know, the journey just continues. You know, I think the big thing for us is, of course, this totally changed like the trajectory, you know, of our family. It totally changed the dynamic of what we were anticipating when we brought home our newborn baby. It was scary and daunting, and I think one of the hardest things is just there's so much still unknown about this condition. It's still so rare. At our hospital, we were told she's one of 11 that they've ever diagnosed, and we're at a pretty well-known hospital. So not a lot of people know about it, know how to treat it, can offer guidance and advice, and so that was just hard. I luckily got connected pretty quickly to the Facebook group of Congenital Hyperinsulinism International Family Support Group, and that was such a godsend for us because finally we just didn't have to feel so isolated and alone. You know, there are families that I've connected with, you know, that were reaching out when she got her G-tube surgery to like see how she's doing. And these, you know, we're strangers, but now they feel like family. And I just think there's something really special there in that these are like all our kids, and, you know, it takes a village, and we're all taking care of them, and just the guidance and the advice and the solidarity that's offered from this organization is just remarkable. So long from Wisconsin.
My name is Shilan. I'm Adam's mom.
My name is Dalal. I'm Adam's sister, and we live in the northern suburbs of Chicago.
In 2000, has hyperinsulinism, hyperammonemia, HIHA. In 2008, Adam was born, and he looked healthy. We came home from the hospital. He was doing okay until after 2 months, he started having seizure. And then we went to emergency room, and they said, "Oh, he has seizure. It's fine. He will be okay. Just go home." Then they start checking a lot of stuff, and they start checking his sugar, and his sugar was about in 20s. Then they found out he has congenital hyperinsulinism.
We went out shopping, and abruptly he just collapsed, and we called the ambulance, and my parents noticed that he was in fact having a seizure.
And then we start seeing neurologists again, and we tried so many medication for his seizure. He was having absent seizures every day almost. Adam is 11 years old, and we still have to monitor him, and at night time I have to sleep in the same room to watch him because of seizures, and some days it gets very overwhelming because the amount of seizures he has, it affects our life.
Although
Congenital Hyperinsulinism International means a lot to us. We learned a lot from them, especially in the conference. Every time I learned something new, and we connected with other families. They have hyperinsulinism, hyperammonemia, which is Adam's type, and they shared their experience with us, which is very helpful.
there are so many people going through the same thing, and we're all in this together.
Thank you so much for those of you who contributed to our videos, and thank you all for joining us this morning. Now we have a little break, and we have breakout sessions starting at 12:50 that you can join through the auditorium space. If you did not join a breakout group during sign up, we encourage you to visit the booths or the networking lounge. After the breakout rooms at 1:30, come directly back to the auditorium to launch Ask the Experts. Don't forget to have your kids at the ready for the video premiere of Down and Up, an HI song for all ages by our very own Jana Pell, and that will be at 2:20. So we hope you all enjoy your little break, and we'll see you back here soon. Thank you.